Hi everyone, it's just gone 4 o'clock and we have more than 40 people in the chat, so we're going to go ahead and start. Today's deep dive is brought to us by AstraZeneca, and the title of the talk is Detecting the PNH clone in Other Hematological Conditions, chaired by Andrew MacDonald, and our speaker is Dr. Lucille Singh. And brought to you by AstraZeneca and in strategic partnership with Sajas and Sasets. And you know us very well by now, the management team. All our sessions are recorded and can be found on our website under Resources Deep Dive. And please, if you have any questions, put them in the chat box and they'll be responded to at the end of the presentation. CBD points will be submitted for every South African attendee. You need to attend with your own registered Zoom link and not in a group. Attend for at least an hour and make sure your number was entered correctly when you signed up. Any queries, you can just email us at admin at bloodsa.co.za. You can join our mailing list using the QR code on the screen, or you can go to Resources, subscribe to Deep Dive on our website. And don't forget to fill out the anonymous feedback survey at the end of the meeting. Ooh. And a short message to say you can follow us on social media if you want to stay up to date with what we're busy with. So the agenda, Lucille will give the talk, and then there'll be Q&A and closing thereafter. And now I'm going to hand over to Andrew to introduce our speaker.
So thank you, Nicole. So welcome everybody to today's deep dive. So we're going to be talking complementopathies. I think the title maybe is misleading because I think Lucille is going to touch a bit on PNH as well, not just other than PNH. But obviously we're talking about rare diseases and which the WHO defines as less than 1 in 2,000, whether that be incidence or prevalence. It obviously depends on which disease, which modality is best suited for that. And people living with rare diseases experience significant barriers in many respects. Barriers to recognition to diagnosis, and all the way on to treatment, and barriers in sort of terms of schooling, because many of these are inherited disorders, barriers in the workplace, barriers in accessing care, and obviously care in terms of many of these diseases is either not available or is extremely expensive, and then therefore limiting the number of people who can actually afford it. So there are a number of issues surrounding rare diseases. There is a rare disease society of South Africa, but the reality is still quite small, and obviously not able to deal with all of these issues. But they are, I think, starting to make some headway. Uh, Today, we're going to be talking about a rare disease, which is part of the complementopathy group, obviously well known to most hematologists, but also some of the diseases that are associated around it. And really the recognition in terms of why we're having this talk now is that we're rather behind the rest of the world. It's nearly 2 decades on from registration of eculizumab, the first complement inhibitor, C5 inhibitor, registration in the United States. And we have just now, as of last week, launched Ultomiris, which is ravulizumab, the longer-acting form of eculizumab in South Africa. And this is now available, obviously, at significant cost. So that's the prompt for this afternoon's deep dive, which Lucille is going to be talking to us about. So Lucille is a clinical hematologist, and she has worked with me at Albert's Cellular Therapy since 2022. And she's now also a principal investigator in some clinical trials at the practice as well. and she's really taken over the data and quality system, and she's really very good at that. And you can see she's obviously also involved in management of hematological entities in South African context, both such as and the South African Bone Marrow Registry. So over to you, Lucille, and we're looking forward to your talk.
All right, thanks, Andrew. Good afternoon, everyone. Let me just try and share my screen. Portion of screen share. Oops. Yes. Okay. Can everybody see my slides?
Yes.
Okay, great. So, yes, thank you for inviting me to speak. So, I've been given the topic of detecting the PNH clone in other hematological conditions. So, I mean, we will be discussing classic PNH, but also looking at small PNH clones in other conditions, and basically, trying to tease out the relevance of those clones. So, this is just a disclaimer slide from AstraZeneca. And then these are my disclosures. I'd like to thank Theo Gardner and Andrew McDonald also for giving me some of the slides in this presentation. Okay, so I thought this was a very useful article, and I thought the title was very poetic. So, Black Mornings, Yellow Sunsets, a day with paroxysmal nocturnal hemoglobinuria. This Dr. Schwartz basically went into the history of PNH as a disease entity, and it's quite a nice short read. Um, so what I got from this basically, so diving deep into the history of PNH, the first clinical case probably of PNH was described in 1882 by Dr. Paul Strubing, where he described a young man with intermittent fatigue, abdominal pain, and severe nocturnal paroxysms of hemoglobinuria. And that's just a screenshot of his article that he published in 1882. PNH was called the macchia fava Micadi disease in the early 1900s. This was two Italian physicians, but basically they lost their right to paternity of the disease because a lot of other physicians had kind of described the entity before them. And then in 1925, the disease entity was formally named PNH by Dr. Inneken. In terms of testing for PNH, I mean the test that was used for it dates back to 1937 when Thomas Hale Ham brought out the acidified serum test, or what we know as the Ham test, and he basically realized that PNH patients, their blood was more likely to hemolyze in an acidic environment. So the bottom set of tubes is from a healthy donor, the top set a patient with PNH, and you can see the middle tubes, when the serum was acidified, there was a lot more hemolysis. If the serum, though, was heat inactivated, there was not much hemolysis. And this basically then alludes to the fact that the complement proteins that were inciting the hemolysis were denatured in the process of heating the serum. Okay, so we get all the way then to the 1980s, and this was the first time that it was discovered that PNH cells actually have a global deficiency of a class of cell surface proteins called GPI anchored proteins. And we know these two proteins now to be CD55 and CD59. They sit on the surface of the red cell. So it's not that they are intrinsically lacking, but what is rather deficient is the proteins that anchor them. And these are termed GPI anchors or GPI proteins. Like the name suggests, the GPI stands for the glucosamine component, the P for the phosphate, and the I for the inositol. So when these proteins are made, there's a lot of steps that go into making them. And the most important gene upfront that's sort of catalyzing it is the PIG-A gene, which produces the PIG-A protein. Just of note, there's a lot of other sort of pig proteins, but the one that we focus on, or that is the problem in PNH, is the PIG-A gene. It was in 1993 then that Kinoshita and colleagues actually identified this PIG-A gene as the cause for the lack of these GPI anchors. Of note, I mean, they say like 1 to 2% of human proteins are actually linked to membranes in the body via these GPI anchors. Okay, so like Andrew said, it's a problem with complement. And this is just, I mean, we've all seen the slide 1,000 times. Just to reiterate, the components that go into it, there's the alternative pathway at the bottom, which is constitutively active, the classical pathway that's antigen antibody mediated, and then the lectin pathway that is activated via infections. And this is a coming together basically of the innate um, and the adaptive immune system in terms of the responses. So one of two things happens as this cascade goes on. Pathogens or cells are then opsonized for phagocytosis. And this opsonization is basically, it's like a signal that says, come and eat me. Or you can get the formation of a membrane attack complex where holes are basically punched into the cell membrane by this complex and the cell lyses. And this is then exactly what happens in classic PNH. So we've got a normal red blood cell, and usually they should have the CD55 and the CD59 on their surface. What CD55 does is it inhibits the C3 convertase. And that's right up top with the complement cascade. The CD59, on the other hand, is inhibiting the formation of the membrane attack complex. So it sort of positions itself in such a way that the complete membrane attack complex cannot form, and the cell then is protected from lysis. Okay, there are also other sort of checks and balances in the complement pathway. So I just put this in for interest sake, so we know the CD55 and the CD59 in green and what they do. But there are also other inhibitory factors. And I'm not going to dwell on this because at this point, I don't think any of them have therapeutic implications in terms of targets. Okay, and then this is just to go off topic for a bit. There is an entity called the PIG-A inherited deficiency. So in no way is it related to the classic PNH that we know with, hemolysis and everything that ensues. The PIG-A gene is located on the X chromosome. So this disease is inherited in an X-linked pattern. It also encodes for a PIG-A protein, again, that's important in that first step in the synthesis of these GPI anchor proteins. But these are different proteins. It's not really the CD55 and 59 that's affected. It's more proteins that are affected that are involved in central nervous system development. So neonates with this disease in severe cases present with seizures, profound intellectual disability, hypertonia, central nervous system malformations, and distinctive facial features. Less severe cases, there may be just some intellectual disability and seizures. And then there's also associated sort of more systemic features like heart defects, skeletal abnormalities, and other visceral anomalies. I'm not sure if the pediatricians amongst us, have come across any cases of these, but yeah, I would believe also that it's extremely rare. Okay, so then the question is, we've got the somatic mutation in the hematopoietic stem cells with this PIG-A mutant population. But interestingly, they've got no intrinsic growth advantage. So what contributes to the clonal expansion of this mutated population? So, the PIG-A mutation alone in these cells, it's insufficient to cause PNH disease as we know it. And there's additional external factors then that come into play in terms of the expansion of this clone. So this is a bit of a busy slide, but basically everything dials back into the interaction or the sort of intersection of all of these diseases. It's not just about that PNH clone, it's about what's happening around it. So there's environmental factors, infections, drugs, treatments that we use. How does it impact on the evolution of the disease? Microbiome alterations, and then all of us are born with a specific genetic background in terms of our immune system and our potential for autoimmunity. And I think a lot of data is coming out in terms of looking at the pathophysiology in aplastic anemia and tracking PNH clones in that setting. Um, So a lot of what I found was actually done in yeah, in aplastic anemia. So specifically, if, in terms of looking for these external factors, things that have been postulated is that perhaps the PNH clone has reduced sensitivity to other apoptotic stimuli and inflammatory cytokines, which may be impacting on the non-mutated population around it. There's immune escape mechanisms that the PNH clone could go through in the setting of aplastic anemia. And it's also postulated that perhaps they are less sensitive to NK cell mediated attack. So, in the same way that they're lacking CD55 and CD59, perhaps they are lacking other GPI, associated proteins, particularly stress inducible surface molecules, which are ligands for certain NK receptors. So this image is basically a visual representation of this theory. So you've got a cytotoxic T lymphocyte. This is now in the setting of aplastic anemia, which is, immune-based. It targets the hematopoietic stem cells, but the yellow PNH clone cells are, relatively undisturbed. We then get a situation where there's this only two purple points, where we've got bone marrow failure or aplastic anemia. And then immune suppressive therapy may also then dictate the way the disease goes. There could be more expansion of the PNH clone or, increase, but not quite clinical or classical PNH as we know it. So there's a lot of studies going into this. And I mean, it's a minefield when you start, sort of searching for potential causes for the clonal expansion. Right, so PNH, it's very rare, like Andrew said. The three main types is the classic PNH that, we all sort of know the presenting sort of phenotype. Then there's these smaller PNH clones in the setting of other bone marrow disorders, and then subclinical or asymptomatic PNH, again, more in the setting of, other hematological conditions. This is not something people are testing for without an indication to test. Classic PNH has the triad of features, so the cytopenias, the intravascular hemolysis with iron deficiency, and then venous thrombosis, especially in atypical sites. If we look at the table on the left, in terms of the most common presenting clinical features, I mean, obviously fatigue, dyspnea could be related to the anemia or pulmonary hypertension or, pulmonary thrombosis. The hemoglobinuria, especially, classically the patients wake up in the morning with this coke-colored urine, and it's thought that they hemolyze more at night because the blood is more acidic at night because of CO2 retention. Abdominal pain, obviously the cytopenias, and then erectile dysfunction, chest pain, thrombosis, and renal insufficiency. Okay, so we are long past, the days of the ham test, which we went through earlier, and flow cytometry, or specifically flare-based, is the way we diagnose PNH. So flare stands for fluorescently labeled aerolysin. Aerolysin is a inactive version of a bacterial protein, aerolysin, and it binds selectively to CD55 and CD59. And specifically, we look for GPI deficient, cells in the monocytes and the granulocytes. So this is basically just the pattern that throws up on flow cytometry. The CD66 is the granulocytes and the 14, the monocytes. And you can basically see that, in the granulocytes, only 72% of them show up with a flare, and in the monocytes 28%. So it means we're sitting with the population that is not binding these. So we've got more or less a 30% GPI deficient population here in the granules, and about 70% in the monocytes. And this is diagnostic then of PNH clones. Okay, so this may seem like a very busy slide, but I think it's a very useful slide, and it's something that should probably be distributed more towards the general practitioners and physicians in terms of who should we be testing for PNH. So we're just going to start with the first two, the C and the A. So symptoms of anemia, and I think the hematologists are sort of very well aware of these indications for testing. But just to go through it, anybody with unexplained cytopenias, and just to reiterate, none of these things occur in isolation. So if there's unexplained cytopenias, especially in the setting of, hemolysis in the red cells, refractory iron deficiency anemias that are non-responsive to therapy, thrombosis in atypical places, and then in the setting of aplastic anemia or hypoplastic MDS, I think it's probably mandatory to look for small PNH clones. It also then has, therapeutic implications down the line. So yeah, if we just focus on the first two blocks, so looking at the PNH clone sizes now in, the bone marrow failure syndromes and the hypoplastic MDS, and that's on the left-hand side, versus classic PNH, which is on the right-hand side. So most of the PNH clones that, we pick up are small PNH clones in the setting of other diseases, right? So low-level clones would be under about 30%. In the setting of a hypoplastic bone marrow, it also, helps you to diagnose the aplastic anemia in terms of saying it's not due to, things like drugs or toxins or inherited conditions. These patients with the small clones of no, there's no benefit from anti-complement therapy. And it also, in the setting of aplastic anemia, may predict response to immunosuppressive therapy. So the thing here is to treat the underlying disorder, but also to track the PNH clone because we know, these things can then evolve. So this clone could become the dominant population in the marrow. Larger clones, more than 50%, are, this falls in with our classic PNH picture. And these are the patients that will benefit from the complement inhibitors. Also, the much bigger clones, one should also then consider prophylactic anticoagulation, especially when the clone size is more than 60% on the cells tested. This table basically just, reiterates what we said with the in the diagram. There's these small subclinical clones. They don't benefit from complement inhibitors, but the larger clones with the classic PNH manifestations certainly warrant complement inhibition as well as prophylactic anticoagulation. Okay, so when does a PNH clone have clinical significance? Again, in and of itself, one has to look at the bigger picture. It's important to review how the test was done, what assay was used, and this is, more for the pathologist. Was the clone detected in two or more populations? They also say here were both granulocytes and red cells evaluated. As far as I know, we're not really looking for clones on red cell populations in our local laboratories. I don't think there's any sort of clinical indication for that at this point. They also mention here about the type 2 and type 3 PNH cells. So basically, type 2 PNH red cells is where you're not absolutely deficient in the CD55 and CD59, but it's less so than normal red cells. And then the type 3 PNH red cells, where it's absolutely lacking. Again, if we're finding the PNH clone in the granulocytes and monocytes, I don't think there's any clinical indication to be testing for this. But maybe one of the pathologists can elaborate on that later. Is the PNH granulocyte clone larger than the red blood cell clone? This could be in the setting, for example, of a transfusion. For very small clones, yeah. So I asked Theo from Oncolab, and I mean, we're not doing what he calls the ultra high sensitivity testing to look for very tiny clones at this point. And then at this point, most of us would have done a bone marrow, full NGS cytogenetics to see whether we're dealing with aplastic anemia or hypoplastic MDS. The laboratory studies in terms of looking for hemolysis, we are all familiar with, and excluding, other causes of hemolysis. And then symptoms. In terms of symptoms, I just want to highlight the thrombotic events and even things like TIAs, yeah. Okay. Okay, and then we move on to, so just focus a little bit on thrombosis. Which patients with thrombosis should we be testing? Again, if there's evidence of hemolysis, so, it's part of the bigger clinical scenario. If it's at unusual sites, and particularly abdominal or visceral thrombosis, if there's associated cytopenias, or, they're non-responsive to anticoagulation, or you're getting recurrent thrombosis, especially, on NOACs. Okay, so thrombosis in PNH is sometimes but underrated. But just to reiterate that thromboembolism is the most common cause of mortality in patients with PNH. 29 to 44% of patients will have at least one thrombotic event in the course of their disease. And then also large data analysis from pooled cases showed that in 19% of patients, the visceral thrombosis actually preceded the diagnosis of PNH. So I think we have to be, investigating, I would say almost every patient with visceral thrombosis, unless you've got another obvious cause, they should be tested for PNH. Again, patients with thrombosis also have a worse outcome. They have a 40% survival rate at 4 years. Okay, so yeah, this is just much of what we have said before. So test patients with thrombosis if they're young, unusual sites, there's concomitant hemolysis, and they've got cytopenias. In the absence of a high LDH, the question is, in the setting of thrombosis, should one be pursuing a diagnosis of PNH? The article that I read, where this sort of data comes from, erred on the side of yes, especially if you don't find another cause. And they say there could be a small PNH clone. It could be, a patient who has been transfused. There could be a partial deficiency of GPI-linked proteins. So, in terms of that type 2 PNH red cells. And like one of the previous slides showed, a significant percentage of patient presents sort of with visceral thrombosis years before the diagnosis of PNH. So in these patients, perhaps we should, more readily look for small PNH clones. Just a slide on anticoagulation in PNH. So this is a bit of a busy slide, but basically it's favoring warfarin. So, the problem here is, patients with PNH, they've got erratic renal functions, they hemolyze on and off. So in terms of the DOACs, the reliability, of preventing thrombosis in these patients is questioned. And this slide basically says that, if you've got high risk features, if you had previous thrombotic events, if there's other hypercoagulable or inherited, factors, if it's antiphospholipid antibodies, etc., you would err on the side of warfarin. I'm not sure why they put pregnancy here, pointing a slide to use warfarin, but we would probably then use, Clexane in pregnancy. The patients that they do say you can use the DOACs in is in patients who have not had thrombosis, who are very well controlled on complement inhibitors, where you've got sort of, reliable or stable renal function, etc. So warfarin is probably the preferred in high-risk patients with thrombosis. Okay, and then finally we get to hemolysis. Which patients with evidence of hemolysis should we be testing for PNH? So we all know Coombs negative. I think it's a knee-jerk reaction for most of us to be, doing PNH testing on Coombs negative hemolysis. Patients who also present with unexplained hemoglobinuria or hemosideриnuria or renal dysfunction. And we actually had a case recently at the Benoni hospital I work at, where I was consulted to see somebody with, profound anemia in the setting of renal failure on dialysis, and he turned out to be a PNH case. Okay, so if we start at the top, if there's evidence of intravascular hemolysis and it is Coombs negative, one could look at other abnormalities. If the smear shows spherocytes, elliptocytes, sickle cells, etc., that's on the left-hand side of this of this graph. Then you do additional tests, targeting that. But if there's no specific abnormalities, flow cytometry is indicated. It's a relatively cheap test. I think it costs about 3,000 for a peripheral blood flow cytometry. The results are available within 24 to 48 hours. I think we're probably not doing it enough. And like I said, this is a slide that should be probably more geared towards the physicians in terms of sensitizing them to testing. I have seen in the last couple of years that they are more likely to look for TTP in this situation, and there's a lot of overlap here. And I think there's probably increased diagnosis of, TTP, especially since the availability of the ADAM-TS activity and antibody levels at some of the labs. And I think it should be a sort of knee-jerk reaction if they're looking for TTP, that a PNH test should be sent off at the same time. Okay, so this was also an interesting article that I found. So, small PNH clones in the setting of autoimmune hemolytic anemia, clinical implications and different cytokine patterns in positive and negative patients. This was a cohort of about 100 patients that they looked at. And it was quite interesting because 37% of these patients had a PNH clone. Two of them actually had quite large clones, 16% and 85%. And they were, especially the one with 85% actually diagnosed them as PNH. So they were excluded from the total analysis. Whether this has implications on clinical practice, not at this point, but it would be interesting to see, as they track these patients, the evolution of the disease in those that are PNH positive, does it differ compared to those who are PNH negative? At the time that this was published, they said the response to, standard therapies was not different between the two groups. The other question is also if one had to then, do the same testing in ITP, would we also see a similar picture? So I just thought that this was quite interesting. Okay, so so we're not really going to delve too much into the treatment, but just in terms of traditional, treatment approaches, one would be anticoagulation, especially in the setting of a history of thrombosis or, other risk factors for thrombosis. I know in the patients that we took off the trial that ended last year, we prophylactically put all of them on prophylactic anticoagulation. Transfusional support as needed, which we know does not come, without issues in terms of quality of life, iron overload, allosensitization, and then allogeneic stem cell transplantation. With the lack of complement inhibitors in our setting, this is still a route that some patients go down. It is curative, or it has curative potential, but it comes with the risk of being highly immunosuppressive, GVHD, rejection, etc. I think Andrew's probably transplanted two patients with PNH in the last couple of years. And we do have another patient coming up in the practice with PNH who's going to undergo a mud transplant. So newer treatment options, the complement inhibitors. So the three on the top, the monoclonal antibodies to C5, eculizumab, ravulizumab was registered recently in the country. And then the small molecules, the iptacopan, danicopan, and pegcetacoplan. I'm not going to pretend I know how to say the last one. Okay, so this just gives you an idea of, where the specific points in the complement pathway are inhibited. The proximal inhibition, that sort of red line, is happening all the way up in terms of inhibiting the C3 and the C3 convertase. And then lower down, we've got the more distal inhibition in terms of inhibition of C5. So, the eculizumab and ravulizumab would fit into this group. Right, and then we're just going to spend the last 10 minutes or so on a case study. So this is a patient at ACT in Pretoria. He's a 39-year-old male, or he was 39 years old when he presented in 2019 with a bicytopenia. Patients were sitting at 52, neutrophils at 1. Um, he had, testing for his hematinics were normal. There was basically, besides this hepatitis B surface antigen that was positive, there was nothing else really that came up from his testing. I'm not sure if this projects well, but his bone marrow trephine is on the left-hand side, and it just showed a hypocellular marrow with reduced numbers of megakaryocytes and reduced granulocytes. Sorry, that cut off. Genetics on the marrow was negative, and he was basically just under observation at that point. I searched, and there was no PNH flow cytometry done on him in 2019. He had no past medical history of note besides the Hep B that was diagnosed at this point. And like I said, he was under observation. And I think he got tired of just following up for, no apparent reason to him, and he was lost to follow up. He then resurfaced in 2023 with progressive cytopenia. So in 2023 he was now 43 years old. He did say, later in 2019, he developed a DVT and he was in warfarin. Lamivudine was started for control of his hepatitis B back in 2019, but he had stopped that. He said on 2 occasions, in the interim, he required blood transfusions in 2021 and then again in 2023, just before he presented back to the practice. When he required blood in 2021, it was in a different city with a different doctor. But his hemoglobin was 6.4. This was the first time he required a transfusion, and his neutrophils had dropped to 0.28. You can see the LDH was markedly up. Haptoglobin was low, so he was clearly hemolyzing, but his Coombs was negative. They were obviously also looking for other causes of hemolysis. His HB electrophoresis at that point was normal. His bone marrow in 2021 did show a PNH clone, but this was not really followed up on. And I don't think he went back to see, the same physician again. Genetic studies on the marrow at that point didn't show any additional sort of acquired mutations. So when he came back to ACT in 2023, bone marrow was repeated. Again, the NGS panel was negative, cytogenetics were normal, MDS FISH panel was done. His viral load had shot up. Like I said, he had stopped his lamivudine. At least he had continued his warfarin from 2019. The bone marrow again did show this large GPI deficient population in the granulocytes and the monocytes. So he's still at the practice, and he's actually the patient that we are considering for transplant. So he's a PNH patient that transformed from aplastic anemia. His most recent bone marrow this year, pretty much the same, no additional, genetic mutations. Um, he's getting intermittent transfusions, probably about one, a transfusion every 4 to 6 weeks. He's got no HLA identical siblings, but he does have couple of 10 out of 10s on a registry search. He was actually, so eculizumab or Solaris is not registered in the country yet, but it is available through a Section 21 application. And we applied for him a couple of months ago before ravulizumab was registered. Discovery actually did approve the treatment plan, but with a 50% copayment. And he was unable to basically fund that 50%. And because of the severity of his disease, the thrombosis, the recurrent transfusions, he actually pushed also, he reads up quite a bit. He's pushed for an allo transplant. He also was not a candidate for any of the trials that was still running, in the last 2 years because of the hepatitis B, viral positivity. So this is just, yeah, the rest of his medical issues. So he's scheduled for a transplant now towards the later part of this month. In terms of what we are choosing to conditioning him with, this is a protocol, John Hopkins conditioning protocol that we found for PNH. And it basically incorporates rabbit HEG, fludarabine, cyclophosphamide, post-transplant cyclophosphamide as well, and then MMF and tacrolimus for GVHD prevention. So this was, decided to put a few slides of eculizumab because this is the drug that we were hoping to use in him that we did get auth for, but like I said, unfortunately could not afford the co-payments. You can see, how quickly these drugs work in terms of just the first dose plummeting that LDH and then keeping the sustained response in terms of dropping the LDH and obviously improving the hemoglobin. The second one shows that it also does decrease the thrombotic events. And in somebody like him who has already had a DVT in his leg, he's got a proposed phlebitic limb. First prize would have been to put him on something like this long term. These drugs are obviously not without, serious potential side effects. The risk of overwhelming infection by encapsulated organisms, shouldn't be understated. So Neisseria meningitis, basically all the complement inhibitors, huge risk for this. The more proximal inhibitors, one also needs to guard against Streptococcus pneumonia, Haemophilus influenza, and then also just other viral infections. The risk for these infections is then mitigated by antibiotic prophylaxis, keeping up with vaccinations, and then patient education in terms of seeking medical advice or being seen as soon as there's symptoms of infection. This is just the vaccination schedule that one would then routinely follow prior to commencing these complement inhibitors and also the booster frequency. Okay, so I mean, reading up on PNH, going through the pathophysiology, the treatment options, the complement cascade, the intersection of PNH with MDS, aplastic anemia, it is a minefield. This quote is, attributed to Aristotle. I don't know if he said it, but it's the more you know, the more you realize that you actually don't know. And I think PNH is one disease where one actually realizes how much more there is, to know. Right, and that is the end of my presentation.
Thank you, Lucille, for that very informative talk. There's a lot of PNH, not so much, no non-PNH diseases, but I see there's one question in the chat box. We'll come to Jaglin's case now, but just a question in terms of do you think it's important that we should be testing red cells? I know the University of Free State has the ability to do red cells. I'm not sure if any other laboratories have that capability. Do you think it adds anything to the diagnostic workup and being able to test red cells for the deficiencies in CD55 and 59, or just look on the flare on the granulocytes and monocytes?
I mean, I chatted to Theo about this also, so if you prove that PNH clone in two populations, I don't know if testing it on red cells adds anything over and above that. Perhaps in the setting where you're only finding it on the granulocytes or the monocytes, there would be value. And then also that article that I found on thrombosis in the setting of no overt hemolysis. Um, without any other cause, perhaps if one were to look at the red cells to see, maybe this patient is sort of in evolution somewhere, that there are some red cells that are partially deficient. But outside of those two circumstances, I mean, I can't really see the clinical utility.
I mean, just to say on the trials we were looking at, and I think in Jehovah's people, it was still there going to be very, very few people who are on anti-complement therapy in South Africa. But if you do happen to see a case that's been treated elsewhere, the one thing that complement inhibitors effectively do is increase the red cell clone size dramatically, because you're not curing the disease, you're just preventing the red cells from demising early due to complement attack. And so essentially what that leads to is a patient who has got a very large red cell clone that is complement this GPH or GPI deficient. And
Mm.
obviously, if you withdraw the drug for whatever reason, whether it's an oral drug, which we don't have in South Africa, or the IV for whatever reason, whether it's funding or other issues, that leads people, and we've certainly had that experience, both Stark and Vernon and ourselves. Of people coming off trial that you actually makes people really very obviously now got a large clone that's now prone and primed to hemolyze, and that can certainly cause significant issues in terms of HP drops, renal dysfunction, and all the other effects of essentially a massive intravascular hemolytic crisis. So I think that's one thing. If we have someone on therapy, may be useful to watch. But we're expecting that. Um,
Mm.
let's go through Hagelin's. I don't know, Hagen, do you want to present your case? I think maybe it's probably easier if you are you able to speak, and then you can go through it. Otherwise, I can go through it.
I can talk about it.
Yeah, go for it.
Uh, Thanks for the good talk there. I have a 15-year-old female. I discussed it previously on another platform, but I just want to see if there's any other opinions. She initially presented with a history of recurrent sinus infections, and she has been followed up by an endocrinologist and treated for the hypothyroidism. And he noted she had a B12 deficiency, and he replaced the B12, and she wasn't improving much regarding her blood counts. But she also had these bruises secondary to the low platelets. She also had no history of increased menstrual bleeding. And her main complaint at the time when she was with the endocrinologist was just fatigue. HB was 12, neutrophils 1.22, and platelets of 60. LDH was normal, Hepto was low, PNH positive for PNH with a small clone, 12%. Bone marrow was low normal cellular, adequate megs and granulocytes. I just received auth for ATG with thromboperin and some cyclosporin. I'm just waiting for her to finish her exams, and then we'll get her into therapy. But is there any other available therapy options regarding the fatigue? Because that's her main complaint.
Mm. So I mean, from what I've read, also in terms of immunosuppressive therapy is probably still the mainstay in the setting of like aplastic anemia with the PNH clone. The other thing, though, they say is we should be tracking these clones, but I couldn't find any guidelines in terms of how often, when, when should you be worried in terms of acceleration, because this clone size still fits into, you know, PNH in the setting of like aplastic anemia. And I don't know if this PNH clone is doing anything with the LDH being normal. So I don't know if it has any sort of implication on the fatigue. I'm not sure, Andrew, if you.
I mean, I actually, I mean, I agree. Obviously, there isn't obviously a lot of hemolysis happening, but obviously the haptoglobin is low, so the least maybe at least some. I mean, I think one of the things we underappreciated in patients with PNH is the degree of sort of that PNH is not just an anemia for transfusion. It's that ongoing intravascular hemolysis and depletion of nitric oxide that leads to an awful lot of symptoms in PNH. And we kind of focus on the blood counts, but a lot of the PNH patients actually have considerable fatigue, dyspnea out of proportion to the degree of an anemia, and then many of the other symptoms, the dysphagia, the abdominal pain, in part, erectile dysfunction can be attributed back to lack of nitric oxide. So obviously one of the ways of obviously getting it as in many of these intravascular hemolytic is possibly supplementation with arginine. Vernon might want to weigh in there, but that's obviously that it might be a sort of many reasons for the fatigue. But I mean, I agree. You still, I think, need to treat a primary issue, which is the the hyperplastic anemia. I'm interested that you managed to get Eltrombopag. The funders have been very resistant against um, uh, giving Eltrombopag in addition to the standard immunosuppressive therapy that's on as available on the EDL. Rita's got a question. Iron status, Jaglan.
Yeah, ferritin 94, saturation 47, iron 29.1. It was looking okay.
Okay.
And she doesn't
Um,
have pernicious anemia. It's not sort of the B12 deficiency. It's not
No,
also autoimmune driven.
I checked, antiparietal intrinsic factors were negative.
Okay. So just pulmonary hypertension is only the other thing off the top of my head I can think of, just in terms of associations and that. I've seen people with, pulmonary hypertension that also just have this chronic fatigue. And sometimes it's not so obvious clinically.
Thank you.
So just in terms of anti-complement therapy, I mean, obviously we have been using primarily eculizumab. That was a bit cheaper than the ravulizumab that was available in the Section 21. I think the primary issue was your patient also lost his job.
You have to
And had to
downgrade his
downgrade
medical
his medical
scheme.
aid, and then we really ran out of funding options. He used to work for an NGO that was funded by USAID, and obviously, given the political issues that have happened this year, he really has run into big trouble when just as potential options for therapy appeared. Um, um, Chronic, Deborah saying transplant. I would have thought not. I don't think she's significantly severe enough to risk transplant, but obviously that's a possibility. Vernon, I'm not sure I'm understanding your cryptic and chronic VTE comment. Would you want to weigh in? And then also, I don't know if you want to weigh in on supplementing arginine in patients with chronic intravascular hemolysis. So I know I'm veering off topic now.
Yeah, no, I was just referring to perhaps small subclinical pulmonary emboli causing chronic fatigue and/or pulmonary hypertension in a patient with unexplained fatigue. And I was also wondering about subclinical kidney dysfunction, but it doesn't look like this patient has significant hemolysis at the moment, at least, if I look at the LDH, although the hapto is low, so small clone size. But anyways, yeah, the arginine is just an experience where we've given arginine to a patient previously. There are two publications on it about where the patient developed pulmonary hypertension secondary to a degree of intravascular hemolysis. And arginine, oral arginine, was able to, at least when you treat it, then the pulmonary pressures go down. And it's a cheap supplement you can buy in the health shops. So, and it leads to increase in nitric oxide, which causes vasodilatation, decrease in pulmonary pressures. But yeah, not pushed by, will probably not be tested in a randomized controlled trial by any pharmaceutical company soon, because there's no money to be made from arginine. It's a relatively cheap substance, but it's not going to help for the PNH itself, as far as we know, at least, more for that particular complication. And if I may, Andrew, while I've got the floor, just
Yeah.
to say, because we've got quite a nice group here, a lot of people, that we are actively busy with the protocol writing as the basis for developing the recommendations for PNH in South Africa. And if anyone would be interested to take part, we've already invited people at the AGM, and we've got a lovely group of people that will be taking part. But if anybody else would be interested to take part, you can email us. I'll leave my email in the chat. You can email me to say that you are interested, and then yeah, you're very welcome.
Okay, thanks, Vernon. Jasmine's got a question about PNH on eculizumab, who has recurrent hemolysis. How would you differentiate between pharmacological breakthrough and clonal evolution? And I would also add, Jasmine, the potential if the patient on distal inhibitors, something like C5 inhibitors like ravulizumab or eculizumab, also the development of extravascular hemolysis through the deposition of subunits of C3 on the red cell and sensitization. So, Lucille, do you want to
So
take
this
that
question I'll
question?
hand over to you, Andrew. I think you have more experience with patients who are actually on the drug.
Yeah, I think it's, I mean, there certainly are, eculizumab is quite a short-acting drug. It has to be given every 2 weeks. And there's certainly people who have fever, infection, or breakthrough can get, or even a delay of a couple of days, but through funding issues sometimes can get obviously breakthrough hemolysis. Ravulizumab certainly is much better in that regard, where it's a longer-acting drug and given every 8 weeks. So certainly that's much easier to manage. In terms of clonal evolution, or just in terms of extravascular hemolysis, obviously most of these patients on distal inhibitors, being Ravu and Eku, do develop Coombs positivity, but then obviously you have to try and distinguish, which can be quite clinically quite difficult to distinguish between is this now an extravascular hemolysis due to the deposition of C3b and C3d on the red cell. That's obviously where the proximal inhibitors come in. So other than add-on, which is also made by AstraZeneca, danicopan. So you continue with both the distal inhibitor Ravu or Eku, and in addition add in danicopan, which is a factor D inhibitor. So obviously inhibiting proximal part of the alternative pathway, or alternatively changing to a completely novel agent such as a factor B inhibitor, such as iptacopan, made by Novartis. None of those other drugs are actually available in South Africa, so it's pretty much an academic question at the moment if patients do develop this. In terms of clonal evolution, we've had patients more sort of on the aplastic sides of PNH. I've had one patient who has had quite significant cytopenias, and then on a clinical trial became more cytopenic and had demonstrated clonal evolution in bone marrow. He actually went on to subsequently transplant. So I think it can be quite a complex clinical situation to sort of navigate. Are there any other questions? Um, just to say that obviously that Eku is potentially still available to Section 21, but Ravu is now available. Obviously, the big challenge now is getting access for people with PNH, for those who need it. So not the people who have small clones. I've certainly got one patient who's got a small clone who has mild cytopenias. Those are the ones that don't need therapy. But the big challenge is going to be getting access funding-wise for most patients in South Africa. Are not going to be able to afford these very expensive drugs. But I think the company is working on this, and we'll hopefully see some movement in the future in terms of access to effective drugs in this admittedly very rare condition. Are there any other questions? Otherwise, I think we're probably going to call it a day. Thank you everyone for attending, and I hope you have a great Monday evening going forward. Thank
Thanks,
you, Lucy.
Andrew. Thanks, Lucille.
Thank you.
Thanks, Andrew.
Yeah, have a great evening. Thanks, Lucille.
All right. Bye bye.